anything they'd like to share with the group? Any announcements from anyone?
I would like to say something, if I might. It's Diane Romaine.
Hi, Dr. Romaine, sure.
Hello. I just wanted to give an update on the senior group, from the senior group. I did some further investigation on the Maryland Healthcare Exchange and the issue of seniors being able to purchase a dental plan on the exchange. Because as you remember, even going back to whenever Mr. Shankdar was in our group, it was thought that that was not possible. Who I spoke to was Dave Stewart, who manages the Maryland Healthcare Exchange in Allegheny, Washington, and Garrett counties. And I spent some time in his office. And as I learned more about that, we do believe that seniors can get a dental plan on the exchange. However, it is unsubsidized in any way. So I'm really looking forward to Nicole Edge's presentation to make some further inquiries on that opportunity. And so I just wanted to make that as kind of a correction or an addition, that it looks like there is a possibility for seniors to independently purchase a plan on the exchange. In looking at the plans available, there are low plans called low that just cover preventive care. Those are between $8, $10, $12 a month. There are high base plans, which are anywhere between $35 and $45 a month. And those are more traditional to a dental PPO and cover some major as well. So again, look forward to the conversation with Nicole and just wanted to give the task force group that update. Thank you.
Thank you.
Thank you. Thank you so much. Anyone else? Okay, well, great. We'll get started. I'd like to introduce our guest speakers for today. First, we have Dr. Marco Vujicic. Did I say it correctly?
You did. Thank you.
Thank you. So great. I've been practicing. He serves as the chief economist and vice president for the American Dental Association. In this role, he is responsible for overseeing all of the association's policy research activities. Prior to joining the ADA in 2011, he was senior economist with the World Bank in Washington, D.C., where he directed the Global Health Workforce Policy Program. He was also a health economist with the World Health Organization in Geneva, Switzerland. He is a visiting assistant professor at Tufts University in Boston. Dr. Vujicic obtained his PhD in economics from the University of British Columbia and a bachelor's degree in business from McGill University in Montreal. Also, we have joining us today is Nicole Edge. She has worked with the Maryland Health Benefit Exchange for almost 9 years, the last 4 of which as the manager of the Plan Management Department. This department is responsible for plan certification approval for marketplace, qualified health, and dental plans. Ms. Edge also oversees the Plan Management Stakeholder Committee, the forum to engage with medical and dental issuers, as well as other industry partners on the implementation of key operational points. We welcome both of our speakers. So Dr. Vujicic, if you can take it away.
Will do, and please call me Marco. Thanks for having me. As you heard from my bio, I'm a heavy numbers person. I lead a team of researchers and statisticians that basically look at a whole series of issues in the dental care sector. And I literally want to spend about 10 minutes walking you through what I think are some relevant recent analyses we've done as you go forward, specifically implementing your expanded adult dental benefit in Medicaid. So just in a nutshell, I have 2 screenshots of who we are. This is just to say we do a lot of heavy scholarly research in my team. Thankfully, it's not just ivory tower, but we're invited a lot to speak with groups like you. We've worked intensely on Medicaid reforms in 4 or 5 states with Medicaid departments the last 3 years. And thankfully, our research is used not just by wonky people, but by folks in your shoes as well. So 2 things I want to cover in 10 minutes. I was asked to give a little bit of perspective of outside of Maryland, what's going on in terms of access to care for low-income adults covered by Medicaid. And more importantly, the second point, I want to give you just my ideas as you move forward. This is unsolicited, but having supported several states through some of these reforms, some things I think you may want to dig into in terms of analysis and data and tracking, and I'll speak more about that. So it's been exciting in dentistry, especially in Medicaid programs. A lot of states have been kind of doing what you've been doing the past few years, recognizing the importance of oral health for their Medicaid adults. Obviously, it's a voluntary benefit, so there's a whole tapestry across the country of what states are doing. You traditionally have had a really strong Medicaid program for children. You're now moving into adults. It's exciting to see a state like you, that I see as one of the leaders in oral health nationwide, kind of dive into this. But anyway, a lot of states are recognizing the value of oral health. We now have a majority of states that in their Medicaid programs do provide what we consider extensive coverage. We can talk a little bit more about that. But again, you now will be coded in this dark teal soon as one of those states. Why I think this is really important is because of this chart. And one of the things we've done in recent years is really look at what are the true barriers low-income adults face across the country. Now, these are national data, but if we look at adults, which is the middle panel, and we look at low-income adults, which is the burgundy bar within the middle panel, and we ask them through various surveys, have you needed dental care, but you've not gotten it because of cost? We see about a third of that population saying yes. Now, what's important in this chart is that by far, any age group, any income group, working age adults who are low income, which is the Medicaid beneficiary population, by far, their biggest issue is affordability. It's not, I don't value oral health, I don't care about it, I don't need to see a provider, I can't find a provider. It's usually not that, it's finances. And that's why it's really important to do what you're doing, is to kind of ease those financial barriers. Okay, so that's all good, but you've already internalized that, you've done it. I now want to focus on this last part before I open it up for Q&A. And this is my considerations for implementation. That's how I phrase this. And so I think a couple of points I like to raise, and particularly at the time you're about to roll this program out. Obviously, the provider network and ensuring access to providers is a big issue. Now, you have one of the best programs around for kids in terms of provider networks and adequate access, etc. I'll show you some data on kind of, surprised me a little bit on, in fact, how few Maryland dentists are participating meaningfully in Medicaid. Yet, you know, they're seeing the kids. There's been a lot of service delivery. But anyway, I think about provider access in 2 ways. You need the right providers enrolled in your program in the right areas, but you also need to make finding those providers really easy for the beneficiary. I gotta say, healthcare is hard to navigate. I don't know the ins and outs of Maryland. So, you know, you may have solved this, etc., but it's something that I feel in terms of like engaging the primary care community to refer people to dental care. How easy is it for somebody to book a dental appointment if they're on Medicaid Saturday morning or Friday night? Can they do this on their phone? Or is it like you got to call 30 providers and 10 of them have a wait list and 20 will see you, and of those 5 will see you Friday if you come at this time? So my point is, we have technology now. This is a big dream of mine. I would like an open table type of app for every Medicaid beneficiary to find a medical care provider via their phone. literally and book appointments, just like OpenTable's design. There are technologies out there to do that, and there are vendors that work on this. It's something I feel we should invest in the public sector. The last one, measuring what matters, is a little bit more longer term and maybe a little bit more provocative. But I really feel we're at a point where in the oral health sector particularly, we have only just started and need to much more intensively measure what matters. And that's things like, do you have data on wait times for appointments? Do you have data on things like, are people's lives improved because of the dental care services in this case, right? Our data show that over a quarter of US adults who are under the poverty level, a quarter of them say, I can't interview for jobs because of my oral health condition. So that's a really major economic impediment to people's livelihood because of their oral health. I would love a system that can track that every 2 years. Like, are you improving that now that you've rolled out this benefit? And things like ER costs, I know Diane has been a big advocate of measuring this and evaluating it. That part you're already on to. So let me show you some research recently we've done. This is complicated data, but you should see shades of burgundy here. And what we've done is in a first of its kind analysis, we were able to analyze where every Medicaid patient got their care in terms of dentistry. This is for children, to be clear, but these are Maryland data. So this is asking, okay, of all the children who access dental care through the Medicaid program, we're able to find out who their provider was. And then we have a whole database of all the dentists in the land, and we have all sorts of robust information. And we're able to calculate some statistics. So let me throw some out here. What this is showing is that about 72% of Maryland dentists aren't enrolled as Medicaid providers, and obviously are not seeing Medicaid patients. There's another 4% of dentists in your state who have enrolled as Medicaid providers, but have not seen a single patient. So they're kind of like shadow doctors or ghost dentists or something. They've enrolled as providers, so they're counted as a Medicaid provider, but we see 0 patients. And the rest is a combination of patient volume. So if you just look at that 15%, the dark burgundy, that basically says 15% of dentists in your state are seeing 100 or more Medicaid patients in a year. Okay, so that's kind of like intensely seeing Medicaid patients. It's about 1 in 6 dentists. Now, why I say when we compare this to all states, we find you actually have a pretty small, dark burgundy line. Now, that may not be such a bad thing, right? If that small population of providers is actually all in the right places, and they're open at convenient times, and they're seeing lots and lots of patients, right? That's a good thing. So my point is, we have various analyses to help kind of triangulate that. We're able to plot every dentist in the US to an address. We know if they're seeing Medicaid patients, etc. We can talk more. Diane knows about our research in that area. But it was interesting. I was expecting, like, if you look at a state way on the left, like Vermont, right? You have about 75% of dentists seeing at least 1 Medicaid patient. That's very different than in your state. And you have about 30% seeing 100 or more patients. So it's an interesting tapestry here. Like, you don't have a ton of dentists doing a lot of Medicaid. You have a very small number. And so again, when I look at this, I'm like, one thing you need to consider is, like, is this enough? And what will you do to engage more providers potentially? I won't go through this too much. Interestingly, your reimbursement rates are slightly above average in terms of when we compare other states. So when we look at, like, your fee schedule for how much you're paying providers for dental care through your Medicaid program, again, for children in this case, these numbers, if you're interested, it's the Medicaid reimbursement rate as a percentage of the private insurance reimbursement rate on average in your state. So you're paying roughly 3/4 of what, like, Delta Dental or private insurers would pay in your Medicaid program, which is pretty high, right? Yet you're not engaging a ton of providers. And that's an interesting disconnect, right? So when I look at this, I'm like, okay, your reimbursement seems to be above average. What is keeping more providers from engaging in the program? And I don't know. It's just a question I ask that comes through in the data. And then I'm going to end with what I meant by measuring what matters. And again, food for thought. I offer up our services if you're interested in partnering. For example, we work with the North Carolina Department of Health to look at wait times. I mentioned this. So just look at the top left of this chart. We were able to survey large samples of Medicaid beneficiaries and those that have private insurance as like a counterfactual, right? And we found that when we look, in this case in North Carolina, we did not see big differences in wait times for adults, right? So that's kind of a good thing. If you have private insurance or Medicaid coverage, if you're an adult, you roughly had the same wait time to see a dentist. For children in North Carolina, it was different, right? There was a much lower wait time for privately insured children than for Medicaid insured children. And this is an indicator, right, of ease of access. This is the kind of thing I feel that really matters. And as you roll out your program, I would encourage, again, we can partner with you if you're interested, but there are ways to kind of track this. So I think wait time's an important thing. I think it's important to track things like, do you have difficulty chewing? Do you have pain in your mouth? Are you uncomfortable about your appearance? Do you have difficulty doing usual jobs? This is really where the healthcare movement is going, right? It's going to outcome-based tracking. It's going to value-based care. And I feel like we have an opportunity with all the reform going on in Maryland and other states to put in some data systems so you can potentially show in 2 years, hey, we put more people in the job market through a dental benefit. We reduce healthcare costs among diabetics because we improved their gum health, and that resulted in lower healthcare costs. That's what the research suggests you should see. It'd be nice to track that. Are you getting people out of pain, etc.? And then how easy is it for them to find appointments? Anyway, that's a bit the researcher in me, but again, it's not ivory tower research. It's very targeted towards, look, what are you really trying to achieve, right? You're trying to get cost barriers down. You're trying to get more people's oral health issues resolved in order that they have better lives, lower healthcare costs, less pain, etc. So I'm going to end there and basically open it back up for questions. I'll leave this up for now in case we need to refer back. But thanks for the time. This was a little bit of a whirlwind overview, but hopefully some food for thought.
Thank you so much, Marco. Definitely very helpful information. And I have a couple of questions to start with. When you show the percentages of dentists participating in Medicaid, can you equate those to numbers? Like how many?
We could, I don't have that handy, but it'd be a simple calculation. You know, this is 15% of all your dentists. So we can do that. Others, yeah, I can't do it now off the top.
Okay.
Yeah.
And also
and we could do this also, sorry, we could do this like by specialty if you're interested, right? Like by endodontics, by ortho, by, you know, we have all those data.
So we've done some mapping with where Medicaid providers are in the state, and you know, we have shortages in, you know, our western region and our eastern region mostly are congregated in our urban areas, but so it'd be interesting to equate those numbers. And my second question, when you are collecting the data, are you getting these from private practitioners, community clinics, FQHCs, local health departments? Where are you collecting this data?
So the dentist data we run, my team operates the master file, and that's through licensure data. So to get the provider database, that's kind of, we spend months and months doing all that, merging addresses, etc. To see which patients see which providers, that's through the claims data that we access through TMSIS, which is a national clearinghouse. So it's basically your Medicaid dental claims from Maryland that get funneled through CMS. We as researchers access those. So it's not, none of this is survey data. It's actually the universe of providers. and the
Mhm.
universe of 100% of the patients, which is cool as researchers.
Great, thank you.
Yeah.
Okay, I see, well, the first hand I see is Dr. Doring.
Thank you very much. Marco, excellent work. Charles Doring, General Dentist in Rockville, Maryland. Marco, in one of your papers, I found it really interesting. Your analogy on providers was a swimming pool. And I would say Maryland is not a very wide pool, but the providers that we do have in the pool are deep in that they're doing a lot of procedures for these, particularly for the children. Just to tell you my personal experience and why people don't sign up is it's not very easy to enroll to become a Medicaid provider or to renew. Just my personal experience, I'm in a group and I'm the only Medicaid provider, which is fine. But when I call to, they want like group numbers and
Okay.
it's very, very, very extremely complicated. And sometimes we're given the wrong information. And then, I had to acquire help and I even got a state senator involved to push my application through. So I think that is a huge barrier. If there's any way, if the came with easier instructions, particularly for those that are in groups and not everyone in the whole practice is enrolling, I think that would be really, really helpful. And then you mentioned about the adult dental Medicaid that we're enrolling and people applying for jobs. And I just want to state again, and I'm just emphatic about this, is we can extract teeth under the new program, but we can't replace them with dentures. So how does a person feel when they go out for a job interview and they're missing their upper front teeth, for example? So I'm just pushing for other things that would help, that are unique to adults and not necessarily to pregnant women or to children. So thank you for your presentation.
I appreciate that. To clarify, so dentures are not covered as part of the expanded benefit? Wow, okay.
That is correct.
Okay. I mean, to be blunt, you can't get any sort of job in America anymore without front teeth. I mean, truck driving, McDonald's, you name it, it's all changed. I mean, so anyways, that's my editorial.
Dr. Romaine?
Thank you. Thank you for being with us today, Marco. Really appreciate your work. The one thing that is a bit confusing is that whenever you say that the Maryland Medicaid program pays at 76%, I know back in about 2016, you did a presentation at MSDA and we were falling at about 54% of commercial, and yet our rates did not increase. So I made a query to Chelsea Fossey because she came and spoke to us with the same data, and she explained to me something about how a different data set was used. So I wonder if you might comment on that, because it's quite a difference, and it does kind of impact, the leverage we have to increase rates, which we get a 10% increase. So could you comment on that first?
Not in depth, Diane. I got to go back to the team that generates those numbers. We did have a change in some methodology, but I actually want to look in because that is a big change, right? Another thing, if the private rates fall, which they do in many states over years, right? That's the denominator. If they're falling and you're not changing your rates, you would see an increase, which is, again, to your point, it's a false message, right? Like,
yeah.
Okay, let me, I know how to get back in touch with you because I don't want to give you an off the cuff answer.
I appreciate that. Yeah. On the second question that I have is there are a lot of dental leaders here and folks like the folks at MDAC, worked with Dr. Natalia Chalmers, our CMS head, and did a lot of data that informed the ability to have the adult dental Medicaid program. Dr. Reynolds and his crew at the University of Maryland, at the MSDA Foundation and independently with you at the ADA HPI. But I feel like we're all kind of doing our own thing. So I'm wondering if you have examples of states where, to your point about keeping measurable data outcomes, who is good at really doing that and how do they centralize that? Because I feel like we could be better about doing that in a more concerted way?
So let's follow up. We're kicking off a project now in Washington to basically put in a tracking system that every 2 years is going to spit out data on these oral health outcomes. And it's specifically designed to be representative among the Medicaid population, the privately insured population, and others. It's specifically designed to be able to talk about racial disparities, right? So they'll be sampling for, white, non-white, etc. So do I know of a Medicaid program that's put in a system that's running like this? No. I think this is what I've been encouraging. We finally are working in Washington, and that's a collaboration, right? So it's with a foundation, with the Medicaid program as well. So I am a big believer in coalitions. So I think, again, you have an oral health coalition, you have this group, you have a lot of folks, well, you have infrastructure that can host this kind of thing. I would love to collaborate. I think you ask a great question. I think you all should invite all these people that you've worked with the past 3-4 years and say, look, we want one central clearinghouse. How do you build it? Frankly, we're building it in Washington. I mean, we're a very data heavy group. So if you're interested, I don't know, I'd love to contribute ideas there, and with whomever we can invite and work with. I am all about a one-stop shop for this, not people fragmented doing their own thing.
Yeah, no, I really appreciate that. And I really think to Dr. Hughes and Dr. Reynolds, that should become another priority of the group. Besides, who is going to collect this data ongoing? I think we need to decide and list out in our report. Thank you.
Marco, I have an additional question. Do you have a magic formula for us to get our providers to enroll?
I mean, we can certainly look at other states that have much, let's say, higher success rates. I think what Dr. Doring said is important. I mean, I don't know enough about the nuts and bolts of enrollment in other states. I want to get back to you on this because our data certainly show some states that do have a huge number of dentists participating. And I just like to inquire with some of my colleagues, like, are there any insights on what works? Honestly, like, as I sit here, and it's easy for me, 30,000 feet, like, the technology exists that this shouldn't be that hard, right? Like Dr. Doring, you have an NPI number, I'm assuming, right? So that if you put that in our database, we could draw up your address, your licensure data, all of this and that. And there's got to be better ways to do this. I don't know. Some states, as I recall, during their relicensure process, is there some process there to be like, do you want to be a Medicaid provider? Like, you tick a box and that initiates a behind the scenes data scrub. And then you get some, is this the correct information you have? Yes, yes, yes. Do you want to enroll? Yes. Like, I'm just thinking the technology exists for all this, right? So again, it may be something where you put, I don't know, you got to look into how you might do this differently. I mean, the story of kind of back and forth and incorrect information, that shouldn't be happening in this day and age. Dr. Doring's data is accurate, very accurate somewhere in somebody's database, right?
Yeah, I would say I was told I needed a group. So if you look into it, I probably have 2 NPI numbers, one for my overall group practice and one for myself. And then to come to find out, I really didn't need to do that application for a whole nother NPI number. So it just was chaos and involved too many people, too many phone calls. And frankly, many people would just say, you know what, I give up, I'm not going to do it. But I hung in there, and I appreciate everyone else who has done that. Thank you.
So there's that part, and then the research, it does suggest the broader administrative issues, right? Like, I mean, how quickly are you paid, and is there how intensely are the quality audits and reviews, reimbursement, as we mentioned. But to your point, you're asking, like, look, who solved this and how can we do this? So I'm going to look into this more. I'm not sure everybody solved it perfectly, but there are certainly examples where states are doing, let's say, better in terms of engaging providers.
Okay, thank you. Dr. Windsor?
You're on mute. Here. Thank you very much. Marco, it was a good presentation. I thought I would kind of, bring to mind some of the difficulties that we have at the school. The logistics of billing sometimes, some of the exceptions and the penal nature of, in other words, if we begin a procedure and come to find out that it's not covered and we haven't gotten the proper authorization and signatures and all, then that becomes a procedure at no charge to the patient. That's part of it. As a private practitioner, I stopped participating in Medicare because of the billing difficulties. It just, it was more difficult to do that. The MSDA has had a wonderful program for many, many years, donated dental services. I found it so much easier to contribute, that way and take on, probably a good dozen patients a year. It was easier just giving the services to the patient and not having to worry about the billing. And again, I'll piggyback on what Dr. Doring was saying. It's just amazing that, that we can do emergency, dental care services for adults, but we can't provide them with those front teeth that give them a smile and some confidence going into an interview to get a job. So, just from my perspective, wearing a couple different hats, that's the problems that I found.
Okay, if there are no more questions or comments, again, Marco, thank you so much, and we look forward to following up with you.
Yeah, and let me just end with, I'm serious, like a big part of my group's mission is to help groups like you and to bring data and information to help drive policy forward. So I'm committed, honestly. Follow up, I'll help in any way we can.
Fantastic, thanks again.
Okay, thank you.
All right. Next, we have Ms. Nicole Edge.
All right. Good morning, everyone. Can everyone hear me okay? All right. So just wanted to speak to you guys today. I know the focus is, from my understanding, healthcare or dental health for seniors. And while the marketplace doesn't have specific or focused dental plans focused on seniors and some of the issues that they may face surrounding oral health, we do have quite a few standalone dental plans, and seniors are allowed to enroll in coverage. As mentioned before, there is no subsidy for any dental care plan, but we'll kind of get into that. So just wanted to preface that before we get started. We can go to the next slide. And go over. Okay, so just a bit of a background. Maryland Health Connection is Maryland's insurance marketplace for qualified health plans and standalone dental plans. So it's where folks can come to enroll, individuals to enroll in healthcare. We are a fairly new quasi-state agency in comparison to some of the other agencies. We've been operational since 2013. For those of us who've been here, seems like forever, but we are fairly new. So just wanted to give a bit of background on what it is that we do here. And I'm at Maryland Health Benefit Exchange. We are the administrator for Maryland Health Connection, and I am in the Plan Management Department. Plan Management Department oversees the carrier or issuer piece of what's happening in Maryland Health Connection. So we manage the relationship with the insurance carriers, both medical and standalone dental. We have a certification process that we oversee every year, also a reauthorization process that we go through in order for those carriers to offer plans on Maryland Health Connection. Next slide. So just some minimum requirements for what we look for in certification. There are not a lot that surround standalone dental just because of the carve out and the way the ACA works. And then also what we can do here in the state as far as regulating standalone dental carriers. But some of the certification standards that we look for is that, of course, all dental plans must meet the pediatric portion of the Maryland's essential health benefits. And then they must meet, of course, the annual limitations and cost sharing set forth by CMS each year. And then the amount of plans that they are allowed to offer on the exchange. So we're looking at that. We also work in conjunction with MIA to look at some of the network adequacy piece. One of the things that we oversee specifically in plan management is that our dental carriers and also our medical carriers are contracting with a certain amount of essential community providers. So we require them to work with or contract with at least 35%. If not, they must then attest to the reasons why and show us the reasons why they can't meet that minimum 35% threshold. So that is also some of the work that we do. So again, most of the network adequacy and provider work we do is in conjunction with MIA, but that essential community provider piece is something that we oversee specifically at MHBE. And next slide. All right, so this is the landscape for 2022 offerings. We are currently in the throes of 2023 certification. So we are working to certify those plans and we'll do that all throughout the summer up through September, but this is what's currently available on the exchange for 2022. So we have 11 plans that are available here. Of course, you'll see the tiers that are available. So you have the low tier and the high tier. Of course, those are just how generous your plans are as far as actuarial value. We have CareFirst, Delta Dental, Alpha Dental, which is a license of Delta Dental, and Dominion, who are currently offering standalone dental plans on the exchange. And then, of course, we have both PPO and HMO plans that are available as well. And next slide. So this is a breakdown. One of the things that you'll see here that makes it look like there are more plans than that 11 stated in the previous slide is that we have GHMSI, Group Hospitalization and Medical Services, which is a license of CareFirst that covers Prince George's and Montgomery County. So it's the same plan with the same coverage as the CareFirst of Maryland. It's just under a different license. So we just carve it out a little bit differently when we're going through detail. And also on that Dominion dental piece, you'll see 8 plans. 4 of those are pediatrics. So I took them out of that count because I know, again, we are, for the purposes of this meeting, focusing on senior care or adult care. So I took those 4 out from the previous slide. But that's just, again, an additional kind of breakdown, some like chart based for you guys to see what the offerings are by carrier and then by tier. Next slide. So just a bit of a plan comparison here.
Nicole, can I interrupt? I'm sorry. Can
Sure.
I interrupt for one second?
Sure.
I think Dr. Romaine has a question.
Yeah, go ahead.
Yeah, if you may, on the previous slide, I was confused by the colors. Is Dominion the biggest or is CareFirst the biggest? The colors are similar, so I just didn't.
Oh, if you can go back to the previous slide.
Yeah.
Oh,
I'm sorry.
so yeah, so these are still these slides here, this slide here, the dental by tier. These are still the amount of plans that they offer. That Dominion, so Dominion actually offers 8 plans, but 4 of those are pediatric only. And so, yeah, we have them because, you know, they are plans that are offered on the exchange, but for our purposes, they wouldn't be available to adults.
Thank you.
Sure. So one of the things that for the premium rates for the exchange or premium rates for the standalone dental plans, what you'll see is that 64 and over, the premium rate will be the same. So once you hit 64 up through whatever age someone enrolls in a dental plan on the exchange, that rate will be the same. The only variation that you'll come across is by region. So if you're, you know, whatever region you're in Maryland, that might differ as far as premium rate, but age won't be a factor in that. So you won't have that different rating band. So I did just a rating area for Baltimore City, which is pretty common for us as far as enrollment is concerned. The age is 64. And these are some plan comparisons for our low options. So I tried to focus on some things that are really important. So you'll see the difference of the premium levels. Of course, for the basic low tier, you have, you know, the premium rate start at $8.96. And that actually is the lowest premium rate available on the exchange for any region. And then those prices, of course, they go up depending on, you know, what your carrier is going to be, but these are all PPO products, and they are all low level of coverage that we have here. And again, the maximum premium that you see is that $36 premium. Then we have this per period maximum. So this is the maximum amount that this plan will pay for dental benefits. So that's what we have here in that period maximum, that per period, or that's per annual. So each plan year, what this plan is going to pay for a person's dental services, the max amount. And then deductible, $50 per enrollee. Most of these have a $150 premium enrollee cap. So if you have 3 or more folks on that dental plan, you're only going to hit $150. After that, they're not going to charge any additional. So that's something that I think is very important for folks to know. And again, the Blue Dental for Care First is $100 enrollee deductible, but they also have a cap on the amount that they will charge once you get over a certain amount of people on that plan. And then some of the benefits, just basic, that I wanted to just show you guys what the coverage looks like and what that out of pocket looks like. Again, and this is for that low coverage option, diagnostic and preventive. These are no charge after deductible. So folks are going to pay that $50 out of pocket when they go to the doctor, or whatever service they're going to go to. They're going to, of course, pay until they reach that $50 deductible. And then after that, there's no charge. So that's when the coverage kicks in for the carrier to pay for the portion of the services. Basic coverage, what we see here, this basic Delta preventive plan has no coverage for your basic, major, or orthodontia. What you'll see is a theme throughout the PPO products is that adult orthodontia is not something that is covered. Something that is always significant to me, and something that I always encourage some of our community assistance workers and partners who are out working with folks who are enrolling, is to look at that waiting period. A lot of dental plans have waiting periods. So folks will enroll in coverage. They expect to be seen by a dentist, and they don't realize that they have to wait until 2 months down the line, 6 months down the line, some even 12 months down the line, depending on what it is that you are enrolling for. Those plans essentially won't work for that consumer. If I enroll in a plan this year and I have, say, a 12-month waiting period for a major service, by the time my 12 months is up, my enrollment is up. And say I don't want to enroll in that plan again, I want to try something new, I want to try a different plan next year, I've basically wasted my premiums and never got my service done. And of course, we know some of these major services are also could be some life-threatening services that you need to get help with, and you need to get managed ahead of time and not behind the 8 ball. So waiting period is always something that is very important to me, and something that I always encourage folks to look into and focus on. So that's just a layout of the low option plans that we have available now on the exchange. And then these are the high options. So we have 3 high option plans available. Again, same rating area and age 64, because again, once you hit 64, those rates are going to stay the same up through whatever age you enroll. And then we have the 3 plans offered: Delta Dental, Dominion, and Blue Dental, which is from Care First, the Care First product. Of course, you'll see here premium rates are a little bit higher, but again, that's because we're dealing with high option plans. And so these plans are paying a little more than the low option plans are going to pay. So the insurance company is kicking in a little more than on those low option plans. Deductibles look the same, and they have the same cap of $150, and I think it's $300 for the Blue Dental from Care First. And then what you'll see here, the significance is these benefits and services, what this looks like. So your diagnostic and preventive, this is a 0% out of pocket for consumers. And then basic, it's a 20% after deductible. Again, something that I think folks really should focus on when coming through the exchange and enrolling in standalone dental plans. Something that I feel is a barrier in both dental and medical for folks is that you have, it sounds great. Oh, you can get a dental plan and it's only going to cost you, X amount of dollars a month. And it sounds really good. What folks also need to take into account, especially in Maryland, we know a lot of folks don't have a ton of money of the population that we're serving, that out-of-pocket costs. When I'm ready to go to the dentist, when I need to go to the dentist, what am I going to have to pay? This is something that's really important for me to be able to focus on and highlight for folks. Basic service, it's 20% after deductible. So not only are you paying towards your deductible, which is a fairly low deductible, if you're dealing with one individual that's going to the dentist, they'll only have to meet a $50 deductible or a $100 deductible if they're going through the Care First option. But you're going to have to pay 20% on top of whatever you're going to have to pay for that deductible if you're going for a basic service, which is something that most folks will utilize in a plan year. Major services, you have a 50% deductible. Dominion, the same thing. Care First is a little lower at 40%. And again, orthodontia not covered under any of these plans. Waiting periods, again, this is something that's important for me to always highlight for folks. Again, here we see Delta, you have 12-month waiting period for major services. Care First, none of the Care First options I'll point out right now have a waiting period. So Care First is the only option that we have, or the only carrier that we have that has no waiting period for any of the PPO services that they offer. And then we can go to the next slide. These are the HMO options that we have. So we have 4 HMO options available, 2 on the low coverage level, 2 on the high coverage level. And again, going through premium amounts start at about $9, $10, go all the way up to about $25, $26. Again, this is for a 64-year-old. So anyone 64 and older will be looking at pretty much similar premiums depending upon where they're located. Per period maximum, what you'll notice is there are no per period maximums for these. So folks won't hit that max amount that the plan will pay for the HMO product. And then there are no deductibles for the HMO product as well. Of course, we know some of the feedback that we hear from consumers about an HMO product is that they feel like they are limited. They have to stay in network. They feel like they can only see certain providers when they go in. And so they feel like it's not as flexible and they don't have as many options. But I always caution folks that, sometimes you want to weigh out your options as far as what you're paying out of pocket and feeling like you might be limited. If you get a really great doctor out of, a limited 50, dental providers, then, is it that harmful to go with the HMO product, especially when you don't have so much out-of-pocket fees to pay for. The other thing about most of the HMO products that we have for dental plans on the exchange is that most of them are a set copay amount. So I'm not surprised when I go to the doctor that I might have, so for example, on this Dominion Dental plan, the Dominion Dental, the Select Plan Basic, which is this first plan you see, these are co-insurance amounts. So I will pay 35% for basic service. Well, I don't know what that basic service is going to cost. It could be $100, it could be $500. So 35% looks very different depending on what that basic service is going to cost. And a lot of times you may not know upfront. A lot of folks aren't calling the provider ahead of time or calling the insurance company ahead of time to see what these rates are going to look like. They're going to the doctor, they need to get services done, and then they are surprised when they get there about what it is that needs to be paid, versus one that has a set copay option. I know regardless, so Delta Care plan right next to it, basic service is a $50 copay. So I know when I go to the doctors, regardless of what it's going to cost for the insurance carrier, my portion will only be $50, regardless of what that service is going to cost to the insurance company. I know $50 is what I'm going to pay out of pocket. So that's one of the things when you are kind of comparing these plans that I, again, try to caution our consumer assistance workers and folks who are in the field dealing with consumers to look at these things and look at, what this means for them, their budget, and whether or not they can actually take advantage of care. It's one thing to enroll in a plan. One of the things that we focus on, and one of the things that I have charged my department with focusing on, is utilization. We have, enrollment numbers, great. We look at enrollment numbers. We want to see enrollment rise. Of course, we want to see more and more folks covered, but we also want to see what utilization looks like. Are folks actually taking advantage of the services and benefits that are offered under their insurance, or are they just paying these premiums and never utilizing the coverage? It makes no sense to have it if I can't utilize it. It's something that is really, one of the things that we want to focus on. One of the barriers or key barriers to utilization is cost. What is it going to cost me if I need to go to the doctor? What is it going to cost me if I need to go to the dentist? And this is also one of the things that we focus on in certification standards. Again, we don't have as much leverage over the dental carriers as we do our medical carriers. But one of the things we try to put in place is making sure they're, cognizant of deductibles. How high are you raising your deductible amounts? How high are you raising these out-of-pocket max amounts? How much are you raising copay amounts? Because folks need to be able to utilize. So this is just some of the information that we have here on the HMO plans, what some of the services that most people utilize and what these costs look like. And then, of course, down at the bottom, you'll notice that there's no waiting period for any of the HMO plans that are offered on the exchange. And then next slide. So this I just wanted to throw in again, because we don't have any senior focused plans on the exchange. But when I was going through and just kind of doing some legwork, I came across a plan on AARP. The administrator is Delta Dental for this plan, and just a comparison of what these look like. So this is the senior dental PPO plan. That's not the exact name. Again, this is from the AARP website. And I don't know if you guys get the slides, but there's a hyperlink where it says senior dental PPO plan at the bottom. And that's a hyperlink to the exact plan that I'm referencing here, just for comparison purposes. So this is a plan that is specifically focused for seniors. And I've aged, this scenario for a 66-year-old, and then compared it to the Blue Dental Preferred PPO plan that is offered on exchange and what these services look like. So you're kind of get a comparison about what the senior focused plans are offering versus what the exchange plans are offering. So we have here, you'll see the per period maximum is $1,500 for the PPO plan from AARP, and then $1,750 for the Blue Dental Preferred. Slight difference in the premium cost, not just, about $20. $10 difference in your deductible each year. And then what these benefits look like. Noticeably, I wanted to see, and this is maybe one of the things that I will charge our dental carriers with doing, is giving us a little more information about some of the specific services and benefits that we see some of the seniors going in for. Like I know TMJ was something that I came across very often, TMJ treatment. None of the carriers that we have had a specific TMJ treatment service, but they came back and said, listen, the service and the treatment can be very different for TMJ. Most of these things are covered, but it depends upon what it is. It depends upon how the provider, the medical provider codes these, or, what they look, how they present this to the insurance carrier, but most of these things are covered. So there is no specific number there for the TMJ treatment, just because, again, it is dependent upon what kind of treatment you're talking about. And then AARP didn't have a specific for the TMJ treatment, so I didn't have really a good comparison to be able to give to our provider, which was CareFirst at this case. But complete dentures, one of the things that we know is something that is a utilized benefit for a lot of folks who are 64 and older. So you're looking at same thing, 50%, and then crowns, implants, of course, gum cleanings, root canals, tooth removals, fillings, cleanings. The AARP offers 3 per year, exams 3 per year, whereas with CareFirst, you get 1 per 6 months, or 2 in a year, more than likely is what you'll fit in. So not a drastic difference in between those two plans. But again, I think that one of the things that our carriers can do, especially if we have an interest in it, is giving us a little more information on some of the services and benefits that folks who are 5 and older are utilizing, and then what those costs look like. And I think that might be, that might be it. Any questions for me? Yes.
Thank you so much. That was informative. Insurance details are a lot to understand, so I can imagine that our consumers have a lot of questions. But one of my questions are, why do rates differ by area?
So the rating regions, we have that difference both between the medical providers and the dental providers. And again, they wanted just the breakdown of Maryland and how the MIA allows carriers to submit rates. And so it's not really something that we can get around. They allow them to rate by region depending on a few factors. And again, that's all kind of overseen by MIA. So it's something that we just have to accept and had to accept that we had this rating region difference. However, what you will notice is not all the carriers do rate by region. So although it is allowed to rate by region, not all of them do. So CareFirst is one that does not rate by region. Their rates are the same across the board. So you will see that most of the carriers don't take advantage of that, but some do.
Thank you. Secondly, I'm not quite sure, why is it acceptable to have a plan that has a 12-month waiting period for a major procedure? If you have a 12-month waiting period, how does the procedure ever get done?
Exactly. So one of the, it's a pain for us as well. And it's something that, again, one of those things, one of the difficult things in being at the exchange, it's a very rewarding process and a rewarding work that we are doing. But there are a lot of things that we don't have control over. A lot of things that we just can't regulate. That's one of the things that we can't regulate. We can't regulate what these waiting periods look like for the carriers. So they are allowed to have those kind of waiting periods for folks. Again, one of the things that they bring up to the Maryland Insurance Administration is that they don't want folks hopping on and off of plans. So I hop on, I get, coverage for 2 months just to get this service done, and then I hop off. And so, that's a big a complaint that we have both, again, in the dental space and in the medical space, is that folks will hop on and hop off of coverage, and carriers feel like it is unfair to them, and they wound up paying more in claims than they have actual enrollees to stay in coverage for 12 months. Our hands are tied in that. I wish we could, take that away. One of the things that I do, again, try to educate some of our consumer assistance workers on when they are working with consumers and they see those waiting periods, is if you know that you have a major service, something that you are looking at, and you want to enroll in a plan that has a 12-month waiting period, you need to stay in that plan. So if I enroll in that plan for 2022, I need to re-enroll in that plan for 2023. And so at the beginning of 2023, I can get that major service done. Again, it sucks, I know, but it's one of the things that we have to try to work with and work around. We don't see that for a lot of the plans that we offer. We do see it for a couple, and it is something that irritates me, but we try our best to try to work around those.
Okay, this is my last question, I promise.
Sure.
Everyone. Okay. Once the new benefit begins on January 1st, do we know how many people on the exchange will now qualify for those benefits?
So again, depending on the plan, some plans, most of our plans, the benefits will kick in right away. So you have coverage the first day in which your plan becomes effective. Other plans, I think we have like 2 plans where your coverage starts the first day of the following month in which you enroll. So if I enroll and I'm effective on January 1st, my coverage kicks in on February the 1st, and then I can start going and seeing providers and get whatever service I want done. Again, there are very few that have that waiting period. Again, none of the HMOs have it. So once you enroll in that HMO plan, you can start being seen immediately with no waiting period. And so the HMO plans are one of those things that, we encourage folks to take a look at and see if that's something beneficial, especially if, you have services and benefits that you want to utilize right away.
So actually, I was speaking of how many would now be qualified for Medicaid.
Oh, well, so for standalone dental, there is no, we don't look at your income. There's no eligibility for standalone dental. Anyone can enroll in a standalone dental plan. What we have seen is that we have a lot of folks who were previously enrolled in Medicaid or are enrolled in Medicaid right now who are looking for an additional benefit, because we know that traditionally the benefits that some of the MCOs have offered in the adult dental space have been pretty slim. So we'll see some of the Medicaid folks actually enrolling in a standalone dental plan as well. before it used to just be very popular amongst some of the pediatric population that we would see a lot of enrollment, but we are starting to see a lot of folks who are on Medicaid enroll in standalone dental plans because of that. One of the things that we are working through now, though, is that we know that there has been an extension of adult benefits via Medicaid that will kick in January 1st. So we are educating folks this year during open enrollment to say, you know, hey, if you're enrolled in Medicaid and you have a standalone dental plan through Maryland Health Connection, take a look at what's being offered. Take a look at your benefits and services and see whether or not it's beneficial for you to stay on this plan. If it's better for you to leave the plan and just only have the benefits that are offered under Medicaid, or what that looks like for folks. And we're also going to make sure that we have some of our consumer assistance folks educated on what are the options that the Medicaid plans will offer, so that folks can make those informed decisions. But there is no criteria for being on Medicaid. Anyone can enroll in a standalone dental plan. There's no eligibility criteria.
That will be very helpful to the consumers. Thank you so much.
Yeah, we are actually doing targeted communication. So we are actually pulling the population of folks that are on Medicaid and have those standalone dental plans and doing targeted, we're sending out emails. For those who have agreed to text message, we are sending out text message, but we also send out open enrollment information each year. And we're also going to put in a notice for that open enrollment with that open enrollment packet for folks to say, hey, this is what's coming, and take a look at whether or not this still benefits you.
Oh, fantastic. Before I get to Dr. Dorn and Dr. Broming, there's a question in the chat I'd like to read to you.
Okay.
Okay. What was the coverage for the low-end option under the diagnostic and preventive care line?
For which plan? I might need to.
Thank you. That was Dr. Hughes. That was actually my question. And I was I was looking at the cost for the low end coverage care on your slide. So before you got to the high end in the HMO, and I just was doing some quick math to try and see what benefit there was to potentially purchasing a low end plan versus trying to pay out of pocket. So yes, that's what I was looking at. So there's no charge after the deductible for diagnostic and preventative care. And then my thought process was, what is the typical cost for diagnostic and preventative care per appointment? Because then if you start breaking out the math, to me, it seems like you potentially aren't saving any money with these plans. There is very little benefit other than perhaps you're breaking out this payment over the course of 12 months. But it doesn't seem to me that you're really going to be able to maximize any of the benefits, because with $1,000 deductible, the enrollment fee, plus your premium per month, I was just trying to figure out the math if that really does work out to benefit people who can only afford that coverage.
Got it. So, I mean, in a lot of these instances, I'll be perfectly honest, and this is one of the things, again, that is a pain point for me in dealing with or trying to, and I don't have a lot of space in the consumer world, but it's something that we work with the consumers each year when we're rolling new plans out. In some of these instances, it doesn't pay. Like on exchange, we have bronze plans, and folks will be attracted to bronze plans because the premiums are low, but they're not very generous plans. And so while you're paying a low premium, you're not getting a lot of benefit out of enrolling in these plans. It's something that we have to educate folks about. It's something that we need to let folks know that, is this bronze plan really worth it? You think that you have coverage and you're paying a low premium, but when you go to the doctor and you're hit with this bill that you're going to have to pay, is that really something that you're going to be able to afford? Or is it going to send you down a spiral of, I can't go back to the doctor. If you have a chronic condition, you can't go back to the doctor. I have this bill now that I can't pay. I have these premiums that I need to meet each month. Does this make sense? So while we have these options available, and there's only so much that we can control about some of these out-of-pocket costs that we have available to the exchange, because if they meet the certification standard, then they are allowed to offer the option. One of the responsibilities that I like for us to take on is to educate folks about whether or not this plan really makes sense. Just because it's available doesn't mean you have to take it. And so for some of the low option plans, and so for example, the deductible, it's a $50 per enrollee deductible. $150 is the cap. So if you have 3 or more folks utilizing a plan, it's only going to be $50 per person up to 3 people. So $150 max is what you're going to pay in a deductible for a family. But each individual up to 3 is only responsible for $50. So while it's not a high deductible, again, if I'm on a budget and I don't have the money to pay $20 towards my deductible and $100 towards whatever this diagnostic and preventive is going to be. And again, depending on your carrier, those are going to vary. Depending on your carrier, the amount is going to vary. It's just very difficult to break down. And if you have to do that much math before enrolling in a plan, is that really the plan for you? And so that's one of the things that we caution, because a lot of times in a lot of these scenarios, the math doesn't make sense. And so we want to make sure folks are aware and have this information, which is why one of the things that I like to focus on is these out-of-pocket costs when we're looking at these plan comparisons, because this is one of the things that's most important when folks are making decisions to go to the doctor. We want it to be that they need to be seen. We want it to be that whatever, the issue is, you can go in and get seen and not have to worry about that cost. But that's just not the reality.
Thank you.
I hope that answers your question.
Yes,
okay.
It did.
Right.
I was just looking at the math. So yes, thank you.
Yeah. It's, again, we have a lot more flexibility in the medical space. We don't have as much flexibility because there's not as much ACA regulation in the dental space as we do in the medical.
Did we lose?
I think we lost our guest.
Yeah.
Oh,
you guys, okay. I'm back on my phone. My laptop died.
Oh, okay. All
And I
right.
didn't even notice that the warning was going off, but I'm on my phone and this is pre-charged, so I'm good to go. So we just don't have that flexibility in the dental space, just because the ACA just doesn't regulate the dental space the same way that they do the medical space. So we can go into and say to a carrier, you need to offer us X amount of plans that don't go over a $1,000 deductible. And then it has to have this, these need to be the benefits. And this is the copay that we can accept. And you need to offer, so many services prior to copay. So some pre-copay services. We can do that in the medical space that we just can't do in the dental space.
Okay, thank you. Dr. Doran, you have a question?
Yes, thank you. Nicole, thank you for your presentation, and thank you so much for advocating for the consumer, our patients. And perhaps from what we just learned, maybe we need to raise the bar on some of these plans, such as the waiting period, and are they really worthwhile for the consumer or not? So thank you for that. I guess my question was, on the percentages of what it's going to cost the patient out of pocket, what is that a percentage of? What is that fee schedule? Is that a UCR, or is that a planned fee schedule? I'm trying to grasp what that is. And then I have one follow-up question.
Sure. So that is whatever the fee is that's negotiated between that carrier and the provider. So it looks different in the HMO space versus that PPO space, and whether or not you're in network, out of network. All of the scenarios that I gave are in network, just because most of our carriers are only providing that in network coverage, with the exception of Care First, which is in and out of network because they only offer a PPO product. So that is the percentage. So whatever that service or that fee is that insurance company is going to get billed for, or what they've already pre-negotiated with the carrier, then the consumer is going to pay that percentage. So if it's a $500 procedure and the carrier has negotiated $500 and they only pay 80%, that consumer is going to pay 20% out of pocket.
Okay, so thank you for that. And then
Sure.
Looking on the provider perspective, I don't know if you have statistics or if someone could provide on provider numbers. And as Marco mentioned earlier, waiting periods. So for example, have PPO and DSO provider numbers stayed steady, risen or declined, particularly during and after COVID-19.
Got it. That is something that we can look into and see if we can get some information on that, definitely.
Thank you.
Dr. Romaine?
Thank you, Dr. Hughes. I just wanted to say, Nicole, your depth of knowledge and your empathy of knowledge from the patient perspective is really incredible. So I think the Maryland Healthcare Exchange is lucky to have you. And thank you for teaching us so much today. The one comment I want to make first is in going to the exchange like a couple of Fridays ago and sitting with the people that take clients through, what they were telling me is the type of presentation that you did for us where you compared the plans, though available on the website for health plans, is not available on the website for dental plans. So from the consumer facing thing, when you go on the website and you look at the 11 plans, you go right to their big 30-page kind of detail sheet. You can't line them up on the computer as a comparison. So I know that was a comment made by the people who were there working on the front line. So is there any thought of adjusting the website to make it a little more consumer friendly? And then I have a couple other follow-up questions.
So sure. So yeah, so actually there is plan comparison on the dental space. And that is something that actually the dental pages, shopping pages, and the medical shopping pages are something that I am directly responsible for. So if folks aren't seeing that, especially our consumer assistance workers, one, I would love if you could, if you are in touch with these folks, and they can reach out to me here at the exchange so we can make sure folks are, and I'm just kind of getting my plug back in here for my laptop, that we can make sure these folks are aware, because the dental comparison is there and on that dental shopping page as well as the medical shopping page. So that is something that is available.
Are aware of that. So we'll make sure that that happens in is there any advantage then for, say, a consumer in Maryland to go on the exchange to buy a dental plan since they aren't getting any subsidies versus just talking to the insurance companies directly? I mean, is it just a matter of a comparison, or what is the advantage of buying on the exchange versus independent with the company or the AARP?
So one of the things is that some of the plans that are available and that the carriers make available for the exchange are going to be different from what they offer on their own. So if you go into, and it's not a huge difference between the two, but the plans that are offered on exchange are, again, need to be certified by us. What they offer themselves don't have to be certified. So where we can kick in and put in some certification standards to kind of oversee or regulate some things that we feel like may be a concern, those things are going to be present on the exchange plans, and they aren't going to be present on the carrier's plan, their website or what they offer on their page, because they don't have to be certified by us. The off exchange plans don't need to be certified by us. And so when we talk about some of the provider network issues, or when we talk about some of the previous certification standards we've put in place, or we say you can't, for example, on exchange, you can't charge a premium for dependents over 3 dependents under age 26. So if you have 5 children, you can't rate for all 5. Once you hit 3, that's it. You can't rate for any more. So if you have 8 kids and they can only rate you for 3, and the additional 5 you're not going to be rated for. So those are some of the certification standards that we get put in place on the exchange to make sure if you're offering a plan on exchange, it meets the certification standard versus the off exchange plans that don't always have to do that.
And just as a final question, you said you were going to target certain groups. Do you have any targeting toward people transitioning onto Medicare, or do you have any way of knowing like how many seniors buy plans on the exchange? I mean, I understand it's not a lot, but are you planning on targeting seniors, for example?
So we have not. It is something that we can do. So we do have the capability to pull the numbers to see how many, dental enrollees do we have at a certain age or over a certain age. We can pull that, information and pull that report. And I think it's something, honestly, that we haven't really taken a look at. One, because we have not had a ton of focus on dental enrollment. I think since I've been in plan management, we've really tried to focus more on the dental space, just because I couldn't understand why we weren't focusing so much on the dental space. It has been, for some years an afterthought, even for us. And I think, a lot of folks treat it as an afterthought. Oh, you go to the doctor, but maybe the dentist. And that's like, why do we have that? The dentist is just as important as going to the doctor, and we have the data to support that. And so this is something that is fairly new for our department to focus and target. I think it's something that's great. And actually, I've had some conversation with folks that, we've talked about me, coming to this meeting and what it was about, and us, saying like, hey, this is something that we should do. We need to get more information about what's available for seniors and make sure that our plans are addressing the needs that they have.
Thank you.
Thank you. Dean Reynolds, you have a question?
Thank you very much. Nicole, thank you for your excellent presentation and taking time to spend with us. I'd like to follow up on Dr. Romaine's question, and it relates to cost, and specifically, have you looked at how the cost of the dental plan, the deductibles and copay impact who subscribes and how many subscribe, is the first part. And then the second part is, how do the cost of the plan, deductibles and copay impact actual utilization of the coverage? Meaning, if I've subscribed and then realized, to your point, that subscribers must understand out-of-pocket costs, do we have data on how best to structure these in a way that allows consumers to subscribe first, and secondly, actually use the plan?
So we don't have a lot of data. What we do here at the Exchange, something that we have been doing for the past couple of years, is we have been working with our marketing partner, GMB, on kind of implementing some of these things. So reaching out to consumers to find out, if you had a dental plan in 2019, but you didn't enroll in 2020 and 2021, what were the reasons that you did not come back and enroll? What were the barriers to you enrolling? Is it just that the plan didn't work for you? Was it financial? So we are working with them, and this is in its infancy stages. So we're just now being able to get some feedback, not enough to really make come out with a ton of reasons why we feel like this is something that's happening, but it's something that we are working towards getting more information on. What is the reason? One of the other things that we're trying to put in place is, if a consumer comes in to the Exchange and has a plan, and they you can log into your account and cancel your plan at any time. Maybe having a reason. We don't want to create barriers for folks to cancel a plan, but we want to know the reason. Why are you leaving? Sometimes you leave a website and the site says, hey, well, why are you leaving us? Please tell us why. Kind of, getting some tracking information so we know what is it that is creating the barrier. I think for us, one of the most, some of the folks that we have on the ground and in the field have been some of our, our greatest source of information on why consumers are leaving dental, or why they not in the dental space. Do they just not know it's available? Because that's one thing, folks just don't know it's available. Again, we are still in our infancy phases, and I'm surprised when I go out at the amount of folks that don't even know Maryland has an exchange or what the exchange is. So we're still building up, along the space of just folks knowing that there's a place for you to come and be able to shop for coverage. So a lot of those things, again, are still in their infancy phases, but something that we are building up. If you guys have, or if anyone has some suggestions, please, I would love to be able to have those. We would love to be able to have that discussion. It's one of the things that we also talk about. We have a plan management committee that I chair, and these are some of the things that we talk about with our carriers and with other stakeholders. How do we get this information in so that we can change our approach and make it better?
Very good. Thank you very much.
Yeah.
Thank you so much. So we'll take our last question from Ms. Freeman.
Thank you. And thanks, Nicole, for the presentation and being here with us today.
Sure.
following up on Dr. Romaine's last question, how many individuals right now are covered through plans purchased on the exchange?
Sure, I can actually, I had that up and then my laptop went out, but I will pull that up now that I have it back up. And let's see. So it looks like right now we have a little over 10,000 folks enrolled in coverage in just the standalone dental space. And then we have a breakdown, and I can actually forward this breakdown, because we have a breakdown of folks who are actually enrolled in medical coverage and also a standalone dental plan. And then we have just folks who are enrolled in the dental plan only and not in any other product that the exchange offers. So I can pull this and get this information out to anyone who is interested.
That would be great if you could do that. Thank you so
Sure.
much.
Okay, thank you so much, Nicole, for being here and answering all of our questions. You are giving us a lot to think about, and we look forward to continuing working with you. And if you're available for questions, we would be, I'm sure you will get many.
Absolutely. Again, my information is on the slide. Folks, please feel free to email us. Again, like I said, we are, still fairly a new agency in the state, and we are always looking to make sure that we are hearing what folks have to say. We have, again, the plan management committee meeting. Folks are more than welcome to join us. I can send that information out to you as well. You're more than welcome to join us. It's a public forum. We welcome all feedback, questions, concerns, and critiques. We definitely, welcome it all. So I definitely encourage folks to reach out.
Great, thank you.
Thank you.
Okay, let's move forward. We don't want any subgroups to feel rushed. So whatever your presentation time takes, we will just have to make adjustments. We're scheduled now for the disabled subgroup. I know there were some connection issues. Have those been resolved?
This is Christy Russell, Dr. Hughes. I'm going to take the disability subgroup report, and we don't have anything to, we don't have a slide deck to share, but I did give Lindsay, I think last month, our written report that maybe she can share out with everybody after the meeting. So okay, I will go ahead if that works.
Yes.
Thank you very much. So in line with what others have done with their reports, I have a little bit of data to share with you just about the disability population in Maryland. So the CDC says that 1 in 5 adults in Maryland have a disability, which is approximately 22%. And then, so I work for the Maryland Developmental Disabilities Council, and we have a prevalence rate that we use for people with developmental disabilities that's assigned to us from the Administration for Community Living. So using that national prevalence rate, which is 1.58%, 95,522 of the 6,045,680 Marylanders are people with developmental disabilities. From the census, 27.3% of people aged 16 and older with disabilities are employed, compared to 70.7% of people aged 16 and older without disabilities. I thought it was important to mention the employment rate for people with disabilities, because we know that private insurance a lot of times comes from our employers. Also from the census, we have 17.6% of people with disabilities, compared with 6.9% of people without disabilities in Maryland live below 100% of the poverty level. And then finally, from the CDC, the disability healthcare costs in Maryland account for 35% of the state's healthcare spending, which is about $21,118 per person with a disability. So one of the things that I was excited to share with you, again, I work for the council, and we work closely with People on the Go of Maryland, which is the leading statewide self-advocacy organization for people with developmental disabilities. I thought that it would be interesting to gather some kind of up-to-date, real live information from people with disabilities about access to oral health care. So in January, I met with them. 10 people with disabilities attended the meeting and provided input. So I thought I would just briefly give a list of the questions I asked and some of their answers about barriers to healthcare and access information. So the first question I asked was if any of them have been to the dentist in the last year. Of the 10, 6 responded yes. I then asked how their experience was. The answers ranged, but most of them said that their experience was pretty decent. They also said that they visited dentists who were able to accommodate their disability. Those who did not visit the dentist said that barriers such as transportation, cost, lack of enough coverage, lack of wheelchair accessibility, and lack of accommodations were the reasons why they felt they couldn't visit the dentist regularly. When I asked them if they had an easy time finding a dentist, the resounding answer was no. They referenced the above barriers, but also included that there weren't many dentists who accept new patients under Medicaid. If they accept new patients under Medicaid, there's a lack of accessible transportation, or that office is not accessible to them. So then I asked, well, how do you get to the dentist? And the majority of them said that they either take public transportation, they have a friend or family member drive them, they have a direct support professional take them, and they said that this is the biggest barrier for them to get care. I then asked if they had to pay any money to visit the dentist, and they said that all of them that went to the dentist said that yes, there are always billing issues, and they always feel that they end up having to pay something out of pocket. They also were frustrated with the fact that Medicaid only covers so much, and they feel that they don't have enough coverage for their needs. When I said what makes going to the dentist easy, the response was that it was easy for the people who had private insurance. People who have Medicaid insurance have a more difficult time getting to the dentist and getting their services paid for. And then I asked what makes going to the dentist hard. And so they talked about, a lot of it was about accommodations and accessibility. So many of the people who were in the meeting were wheelchair users or had physical disabilities. And they said that spasticity is one of the issues that they face. And when they have procedures done, it's really hard for them to control their muscle spasms and find dentists who are able to work with that. A lot of them referenced that dentists leave, whether it's leave the coverage, so the dentist no longer has the coverage that they have, they leave the office, or they retire. And they said it's really hard for them to find a dentist that they like, that can accommodate their disability, and then that can stay with them for a length of time. Dentists not taking the insurance anymore. And again, wheelchair accessibility, I think this came up in just about every question I asked. They said if they can't get into or around the office, it's a barrier for them to go. And then another thing that they mentioned was that dentists just don't understand what accommodations they need and why they need them. And then the final question I asked was, what do you need to be able to do to visit the dentist 2 times a year? And the unanimous answer was that they needed more dentists who understood people with disabilities. And then they had some other additional talking points that were outside of the list of questions that I had. So just in summary, they said that they would love to see a dentist registry that highlighted dentists who are disability friendly, have accessible offices, and accept Medicaid. They would like to see more information about visiting the dentist in plain language so that it's easy for them to understand. And so they also talked about, and I'm not sure if you're familiar with child life specialists, but child life specialists are many times in hospitals. They're a social worker who work with children who are getting procedures done in the hospital. Some of the people in the meeting had experience with them before. Child life specialists help prepare people for procedures that may be done. And they said a liaison between a dentist and themselves who can provide information in plain language and be a support person before and after the procedure would be helpful for them, like a child life specialist. And then I also have some notes from Sarah, who is another one of our members of the disability community, who offered some additional information from her perspective at Chop Tank Community Health Systems. So she agrees that there is a need for more dentists to accept Medicaid, that we need to increase access to dentists who provide sedation dentistry to Medicaid patients who require sedation, that the annual expenditure caps do not cover all of patient needs, including crowns, dentures, and fillings, and that's something that we should look at addressing. And she also agrees that transportation is a barrier and there's a lack of providers who provide care outside of their office. So one of the things that was talked about was potentially like mobile clinics so that we can get to people who can't get to a dentist office. So we have a few recommendations that are very much in line with some of the other recommendations that have been made by our other subcommittees. One of the things that we think we want to look at is increasing the Medicaid rates for dental procedures so that we can include sedation. Create plain language information and resources that talk about the importance of regular dentist appointments, how and where to locate providers who accept Medicaid, and what procedures are covered under Medicaid. Mobile dental clinics that coordinate with providers in long-term services and support settings so that we can reach patients who don't have accessible transportation, and then increase the annual expenditure caps. So that is our report. I'm happy to take questions, or I can follow up or have any of my other committee members follow up if I don't have the answers.
Great, thank you so much, Christy, for those facts and those recommendations. This is a question for Lindsay or Tyler. The presentations that we've been given and the reports, they will be in the portal, or how will they be accessible?
Yeah, we have been both circulating them by email and uploading them onto the Google shared drive.
Oh, okay.
I just now sent out an email that included the presentations from today along with Christy's document that she just shared.
Okay.
Circulated that on email, and we'll also make sure that that's uploaded into the Google Drive.
Great, thank you. Does anyone have any questions? Okay, if not, thank you again so much. And then we will move on to our next subgroup, Medicaid.
Thank you, Dr. Hughes. Good morning, everyone. This is Mary Backley. I am with MDAC, and I'd like to first acknowledge and thank my co-subgroup members, Jennifer Bremen with the Maryland Managed Care Organizational Association, Dean Shiflett with DentaQuest, and Brooks Woodward with Chase Brexton Healthcare. We've been working and met several times over the past several months and addressing the very broad topic of Medicaid. Thank you, Lindsay, for managing the slides. If you can go to the next one, please. As a reminder, the Medicaid population subgroup goals were really to identify the target population within Medicaid and define each group, and then look at the target population in reference to the barriers identified in the Oral Health Task Force work plan and which barriers might impact the group. And as well, we were tasked and reviewed proposed solutions and actually made recommendations that would address barriers faced by each population group and how solutions or our recommendations would impact the group. Okay, Lindsay. So the subgroup identified and defined 5 Medicaid population groups: infants ages 0 to 3, children ages 4 to 20, adults, and I'm sorry, I apologize, that's ages 21 to 64, that should have been in there, pregnant women, and dual eligible adults. The resources for the numbers identified for each population group are included in this slide. And the total Medicaid population collectively for all groups is just under 1.5 million. Okay, Lindsay. As a reminder again to everyone, the task force work plan identified 6 barriers to care: insurance, geography, race, ethnicity, socioeconomic, workforce, and education. Lindsay, thanks. For each Medicaid population group, barriers were reviewed in 3 distinct geographic areas within Maryland: rural, urban, and suburban. Okay, Lindsay. So as many of you are aware, the state of Maryland consists of 23 counties and Baltimore City constituting 24 local jurisdictions. Anne Arundel, Montgomery, Prince George's, and Howard counties are a blend of suburban and urban and semi-rural portions. Baltimore County is mostly urban with suburban and semi-rural outskirts. Thank you, Lindsay. The proposed solutions and recommendations which we came up with are made to address barriers to care experienced by all 5 population groups that the group identified. And the level of impact of these recommendations are designated in each subgroup and within each group geographic location. So that's rural, urban, and suburban. So what is impact? We define the level of impact based upon the CDC definition, which is the effect that interventions have on people, organizations, or systems to influence health. Solutions to address these barriers were recommended based upon the level of need. So we had high impact, high need, moderate impact, moderate need, low impact, low need. So in effect, geographic areas with the highest need for a particular recommendation that we made were considered high impact within each Medicaid population group. Areas with the lowest need of a recommendation were considered low impact within each Medicaid population group. And it's important to note that our recommendations are based primarily on our knowledge, experience, or expertise that each of us brought to the discussion. Okay, Lindsay. So in summary, before I go into specifics regards to impact and population, this slide basically illustrates how the subgroup approached its work, its review, and how we came up with proposed solutions to address barriers to care and need within each population group. Okay, Lindsay. I'm going to start with rural areas, which I don't think is going to be a surprise to anybody on this task force. In rural areas, all 5 population groups are either underserved or unserved due to the existence of all 6 barriers identified by the task force and are at a greater level of impact as compared to urban and suburban areas in the state. Okay, Lindsay. I'm going to delve into the individual populations because it does vary depending upon, or our interpretation, it does vary depending upon geographic location. So the infants and children, high impact is felt in suburban and urban, and addressing the barriers of race, ethnicity, we feel socioeconomic, insurance, and education. Although the state offers dental insurance to these population groups, infants and children, excuse me, via the Maryland Healthy Smiles program, not all eligible infants and children are fully utilizing the benefits. Parents, guardian, caregivers' knowledge of and access to Maryland Healthy Smiles, greater knowledge will have a high impact on infants and children for these specific barriers. Okay, Lindsay. Whereas due to the greater availability of both workforce and as well as transportation options, our recommendations will have a different impact on the need in both suburban and urban areas when compared to rural areas in these two identified barriers. Okay, Lindsay. The level of impact on these three barriers, socioeconomic, insurance, and education, we think will be dictated by implementation of the Maryland Medicaid adult dental coverage, which is scheduled to begin on January 1st of 2023, as well as outreach to the Maryland Medicaid adult population by the department and ASO. I will make a side comment. I was really encouraged that the Maryland Benefit Health Exchange is also going to be doing outreach and education on the Medicaid adult dental coverage as well. That I think that'll be of a tremendous assistance. As many of you are aware, the adult dental package includes preventive, diagnostic, restorative, and periodontal care and does not have a cap on annual services. Okay, Lindsay. Again, due to the greater availability of workforce, larger number of providers, as well as transportation options, we believe recommendations will have a different impact on need in both suburban and urban areas. In addition, we also think with the barriers of geography, race, ethnicity, and workforce. The prevalence of support systems also, as well as case managers, such as community health workers, doulas, social service organizations, is far greater in suburban and urban Maryland when compared to rural Maryland, and also contributes to these moderate and low impact ratings. Okay, Lindsay. And finally, the fifth population groups, pregnant women. Pregnant women are highly impacted across the urban and suburban geographies based on their socioeconomic status. Some may not qualify for the Maryland Healthy Smiles program because their income is too high to qualify and they can't afford to pay for private coverage. For those who are employed, their employer may not pay for coverage or offer coverage. Others who may qualify, the lack of resources needed to seek enrollment in the program exists. Others in this group may also have language barriers. Okay, Lindsay. And so similar to that pointed out earlier, due to the greater availability of workforce and transportation in urban and suburban areas, we believe the recommendations that we are about to show will have a different impact on need in both suburban and urban areas. The prevalence and support systems, as referenced earlier, particulars doulas and community health workers, is far greater in suburban and urban when compared to rural. Okay, Lindsay. These are our recommendations, and they are quite numerous, and many of them were expressed today by our colleagues during the other subgroup presentation, as well as Marco earlier this morning, as well as previous meetings by other subgroups. So I take, I'm very pleased to see that we are all thinking same minds in several areas with the solutions that we're recommending. Is it complete? By no means, but we feel that these solutions address the major issues that we all learn of or encounter or experience in our work that will significantly improve the availability of dental care and equitable access to dental care for all 5 population groups in the identified barriers by the task force. So this is, of course, again, we're talking about the mobile providers referenced earlier, the provider incentives. I'm not going to read them all because I understand the time limitations, but again, many of these were addressed earlier, including the dental reimbursement rates, the development of a periodic review for Medicaid reimbursement rates. That's something that has not existed. Which we think would be not only an appropriate step, but also possibly encouragement for providers to join the Medicaid program, knowing that the reimbursement rates would be periodically reviewed. Expand reimbursable services, increase the number and type of services. In terms of workforce, we've spoken about it before in terms of expanding provider network in various areas, in providing relocation incentives, particularly in rural areas of the state, and of course, education, the retention and enrollment campaigns, expand dental promotion and education campaigns. Again, all these and each of the barriers have been brought up at one point or the other and reinforced during the discussions of the task force throughout the past year and a half. So go ahead, Lindsay. So in closing, the Medicaid barriers to care impact identified in the workforce plan impact all 5 population groups. The impacts range from high to low based on the population. And in rural areas, all 6 barriers to oral health services are highly impacted by the proposed recommendations within each population group. In urban areas, socioeconomic barriers were identified as high impact for all populations. And additionally, socioeconomic was the only barrier that is highly impacted by proposed recommendations in all geographies. So that is our report. Go ahead, Lindsay. These are additional references that we use to support our deliberations and discussions. And I thank you all for your attention. I thank my co-group members for their expertise and contributions. And I open it up to any questions or comments.
Well, I just want to make a comment. Thank you so much for your extensive report. That was very helpful. And we'll give the group good guidance in making recommendations. Thank you. Does anyone have a question? I see Dr. Doran has made a note in the chat that you all can look at.
Dr. Romaine has a comment or question.
Oh, yes.
Thanks. I just want to say thank you, Mary. That was so comprehensive. We really appreciate it. I wonder if you could speak, though, on behalf of your role at MDAC, as far as like where you think MDAC's priorities are going to be overlaced on the Medicaid presentation that you just gave. Like if you could speak for your group as far as how you're feeling and where you guys want to go in the coming year. I'd love to hear about that.
Well, I think we're going to be addressing all 6 of the barriers in one form or another. Our mission is to improve the overall health of all Marylanders, really focusing on oral health equity, equitable access to care, which I think all of these barriers and all the recommendations are going to address. One thing that I have realized is that the network has really, over the past year, actually several years, has been incredibly involved in terms of advancing our goals and objectives. So I think given the momentum that's been happening, we're going to be addressing all recommendations in one form or another.
Thank you.
And hopefully getting a larger staff.
Dr. Doran.
Thank you, Mary, for your presentation.
Oh, mute. You're on mute.
Thank you, Mary, for your presentation. I put in the chat that with the abbreviation early and periodic screening, diagnostic, and treatment, just for clarity. And then on that thought, something that MSDA leadership is seriously considering, and we've looked at this for older kids before, and unfortunately legislatively it has not gone, but actual designated screening oral exams for school-age children. And one thought is looking even at pre-K and younger kids in daycare, and how would that look in screening? It's hard to mandate such a thing. And when we did it for the grade school kids, we ran into a lot of opposition from school nurses. How dare we mandate something they're already overworked. But I just want maybe your group and also the children's group to consider some options and give us feedback for the MSDA, because we are looking at that as a possibility. So thank you again for your presentation.
Thank you, Charlie, very much. I appreciate that. Screening's one of the recommendations that this group certainly addressed. It's something from DAC that remains, frankly, the Dental Action Committee. One of the recommendations that's outstanding is the systematically provide dental screenings and case management for public school children. So I greatly appreciate you bringing that up, and I'm really happy to hear MSDA is working and leading that as well. Thank you. Do my co-group members have any comments? I apologize.
No, nothing for me, Mary. Great job delivering that.
Thank you.
We have a question from Sarah.
Sorry, mine's not really a question, just a statement. Okay. So I work for Choptank Community Health, and I'm one of the school-based providers for the Eastern Shore. And on the Eastern Shore here, I can tell you that, so I work with Talbot County Schools, Caroline County Schools, Kent County Schools, Queen Anne County Schools, and Dorchester County Schools. And I have had so much support from the nurses at the schools, and, you know, dental screenings that's what we offer. And it's for anyone who signs up for the program. And the nurses are the ones that support us and send out the medical history forms. If a child does not have insurance or is not covered by insurance, I still see the child, whether that's just looking at them and seeing if I see anything that's a suspicious area where they need to go see a dentist. I contact the parents, I reach out at home. We also aid and help them if they aren't signed up for Healthy Smiles and can be signed up for Healthy Smiles. We help them do that. But honestly, the nurses here at our schools are very supportive of the program. And most of the kids that I do see, unfortunately, if they're not seeing me for their dental screenings and their cleanings and their sealants and fluorides, they don't go to a dentist. And the other thing that we've been able to do with Choptank, we have a dental case manager here, and I reach out to her. And if there is a child that needs to get to the dentist, even if it's not necessarily coming to see us at Choptank, but another pedodontist in this area, we'll help provide them with transportation to get them to that dental appointment. So I do feel like we're very fortunate here where we have that support and backing that we need to get the children seen here.
Thank you so much, Sarah. That's good information. We see these screenings being done in other parts of the country and, even in our state, and we'd like to see something like that statewide. Charlie?
Yeah, I was just going to echo, thank you so much, Sarah, for what you're doing there on the Eastern Shore. And when we had the hearing in Annapolis, unfortunately, it was assigned to Ways and Means Committee because they take care of school budgets and things like that. And I'm really sad to say most of the opposition came from school nurses in Montgomery County, just to be specific. I'm looking forward to working with you if we do put a bill forth, having you come to Annapolis and testify about the great things that you're doing there. So thank you so much.
Great, thank you. If there are no other questions, Dr. Doring has a very brief presentation he'd like to share with us following up on our previous meeting. Dr. Doring.
Okay. Sorry, I was muted there. Can you see my screen?
Yes.
Okay, thank you. First of all, there was a question. I want to thank Dr. Alexandra Fitzgerald for filling in for me last year. I was out of the country at the last meeting, but I did come back and listen to the video. And I know Dr. Hughes posed a question and didn't have time. The speaker wasn't there to answer it. Was it dealing with the community dental health care coordinators, the CDHCs? And I borrowed some slides from Dr. Dunn Crumbly at the Oklahoma University College of Dentistry that would shed some light on those questions. First of all, the CDHCs work in rural and urban communities, the underserved, disadvantaged communities. And where would they be located? In community health clinics, federally qualified health centers, certainly in Oklahoma, tribal health centers, Indian health services are a big thing. So CDHCs can also be based in other community sites, such as schools. We're talking about the doing the early childhood screenings, WIC programs, Head Start centers, long-term care facilities and other institutional settings, social service agencies, and in fact, community dentists. If you think about an existing staff person in your office, a hygienist, front desk person, dental assistant could go for this additional training and really kind of coordinate the care. That would be an added benefit to the practice and would certainly add to the bottom line of the practice and the income for that individual as well. So I think it's got some growth potential. So that, I think the just was a list of who might qualify for being a CDHC. Who could these be? Certainly high school graduates, dental assistants, dental hygienists, other healthcare service providers, nurses in emergency departments, for example, social workers in hospitals, community healthcare workers without any dental skills would gain from going through a program like this. So I just wanted to add some clarity to that. So thank you for the opportunity.
Oh, certainly, and thank you. It's good information as we consider our recommendations for workforce. Dr. Carlson, you have a question?
Yes, thank you. Thank you for that, Charlie. Are there any educational programs for the CDHC type of person in Maryland that you're aware of?
I'm aware that, and Diane can chime in too, Allegheny College was considering putting that as a unit in their hygiene program. That was pre-COVID. I think that was kind of put on hold. We could certainly reach out to them, but there may be other, they are being utilized in Western Maryland and in Eastern Shore federally qualified health centers already. It's not a state dental board certification issues because they're not providing actual dental care unless they're already licensed, say, dental hygienist.
So I'd be happy to comment more. Allegheny College of Maryland put a cohort of community health worker trainees through last year in a collaborative program with a community college in North Carolina. And they had a big grant. So really the cost was nothing. Currently, they're exploring that for future years, but that grant has gone away. So I know at West Virginia University Dental School, the community dental health worker curriculum is within the hygiene school, which is great. But what we're finding in Western Maryland, when we look side by side at the curriculums, many of the community health worker curriculums in Maryland that are put out by groups like AHEC, Area Health Education Center, really overlap like 99% with the ADA's Community Dental Health Coordinator program. It's the same kind of curriculum. So a lot of those trainees through AHEC really serve in the dental space there. So there's a lot of overlap would be the idea. Still need to do more training, specifically if we want to make a CDHC designation. That does not exist, as Dr. Doring said, under current community health worker specializations in the state of Maryland.
Thank you.
Dr. Doring?
Yeah, yes, thank you. I did, since we're on the topic of community colleges, I did want to say that Maryland State Dental Association and myself reached out to the administrators for all the community colleges across the state of Maryland. And we had a very good discussion on workforce. And just to kind of illustrate how crucial the situation is for dental assistants in particular right now, I ran a search through a major job search engine, and there were over 450 job searches looking for dental assistants in Montgomery County alone. That's 450. So we're really at, and what happens if you don't have enough dental assistants, it slows down our ability to see patients in a timely manner. Room changeover, sterilization procedures just all take longer when we're understaffed. That being said, I did get, as a result of that conversation, I did get in touch with Prince George's County Community College, and they are in serious need of an instructor for their dental assisting programs, which actually start in August. So I said I would reach out in various ways to try to find an instructor for them. So if someone's interested, a great job for a maybe semi-retired or retired dentist, dental hygienist, dental assistant, very versed and willing to educate others, certainly get in touch with me and I can get them in touch with Prince George's Community College. So thank you for the opportunity.
Certainly. Okay, so it is a little past noon. If no one else has any questions or comments, our next meeting is scheduled for August 18th from 4 to 6 p.m. We will have presentations from 3 subgroups, pediatric, adult, and immigrants. We do not have any guest lecturers scheduled. If there is anyone you feel like would benefit the task force, please let us know sooner than later so that we can see if we can get them scheduled for that meeting. Because after that, we plan to start forming the report for recommendations so that we can all discuss it. So if we don't, oh, I'm sorry. I was going to ask Delegate Bagnall if she had any comments, but I think she has had to leave the call. Okay. Dean Reynolds, do you have any?
Nothing to add. Thank you very much.
Okay. All right. Thank you all so much. Enjoy the rest of your summer. We'll see you